An Air Force student pilot reported a near loss of consciousness on the third split-S portion of a cloverleaf while solo. Immediately prior to the cloverleaf, he experienced tunnel vision during the 3G pull-up for a routine loop. While inverted at the apex of the loop, he detected signs of an impending stall and unloaded the stick to abort the maneuver. He tried another loop and once again experienced signs of an impending stall. The student was indoctrinated with a healthy fear that stalling while inverted could result in an unintended spin. He reported the episode as a near G-lock, and his flight instructor decided to attempt duplicating the profile with the student later the same day. The instructor pilot noticed the student's breathing intensify with each high G maneuver, and the student complained of tingling in his fingers. On the third loop of the cloverleaf, the student lost consciousness. About 20 seconds elapsed before he recovered enough to recognize that he was in an aircraft. The instructor referred the student to the flight surgeon. The exam was normal, however, voluntary hyperventilation reproduced an identical tingling sensation. The flight surgeon noted that the student was tense and underconfident compared to his peers. He felt hyperventilation was a more likely explanation of the actual G-lock than low G tolerance. He provided reassurance and recommended 2 or 3 acrobatic rides with an instructor. After an accident claimed the life of an instructor pilot in a sister flight, the student admitted that he doubted his ability and motivation. He was not progressing well and subsequently requested to be eliminated from flight training. Welcome to Aerospace Medicine Grand Rounds. Speaking about this case today, we have Dr. Roger Bisson from the Civil Aerospace Medical Institute. Please welcome Dr. Bisson.
Hello. This case is very similar to an incident that happened in my undergraduate pilot training class of 7606. Hyperventilation is more common than hypoxia with very similar symptoms. The symptoms we're most concerned about include dizziness, lightheadedness, tingling, visual disturbances, loss of muscular coordination, inability to think clearly, feelings of detachment, numbness and fatigue, and also physical signs can include palpitations, chest pain, tremors, and a feeling of impending doom. We'll use this event to discuss aeromedically important effects of hyperventilation. So who would like to get us started?
Yes. Do you think the flight surgeon's assessment was correct? And how would hyperventilation contribute to this student's G-induced loss of consciousness?
The brain is particularly sensitive to carbon dioxide tension. Hyperventilation leads to hypocapnia, and hyperventilation disrupts autoregulation of cerebral blood flow. Increased arteriovenous gas differences have been measured which are severe enough to cause cerebral hypoxia. If you combine hypercapnia with G loads, the result is cerebral hypoxia. If you add a G straining maneuver, Valsalva, or pressure breathing, they can all result in syncope. I think the flight surgeon's assessment was reasonable.
Well, what about the cardiovascular system? Hyperventilation should cause cardiac output to increase. Wouldn't this protect the pilot from G-lock?
That's correct. Hyperventilation will result in increased cardiac output due to increased heart rate. However, vascular resistance and mean arterial pressure fall. Arterial venous restriction in the limbs shifts the blood centrally. Reduced coronary blood flow and reduced cerebral blood flow lowers PO2 in the heart muscle. This lowered PO2 is actually sufficient to detect myocardial ischemia on an ECG. I have to wonder if older aerobatic pilots aren't inducing myocardial ischemia to a significant level during their aerobatic maneuvers. Hyperventilation causes alkalosis. Blood pH values of 7.8 have been recorded. This causes a shift of the oxyhemoglobin curve upwards and to the left. This means the blood can carry more oxygen at any given PO2, but will offload less oxygen at the tissue level.
Yes, doctor, it seems to me that this case presents a mixed picture. Hypocapnia caused by hyperventilation may be the main culprit, but despite the increased respiratory rates, you've also described hypoxic effects affecting the brain, heart, and peripheral circulation.
That's an outstanding observation. The large surface area of the lungs and microcirculation and the affinity of the hemoglobin molecule results in very efficient gas exchange until oxygen concentrations get very low. This happens at a PO2 of about 60 millimeters of mercury, which is an altitude equivalent of about 8,500 feet. The student was getting some oxygen through his aviator's mask, but he is also practicing fairly aggressive and sustained aerobatics. This causes the blood flow to be directed to the base of the lungs and also causes small airways to collapse. During aerobatics, the upper half of the lung is minimally perfused and air is trapped. This causes a ventilation-perfusion mismatch, which leads to decreased oxygen levels under high GZ loads. Hypocapnia exacerbates effects by decreasing blood flow to the brain, coronary arteries, and peripheral organs. The increased pH due to hypocapnia shifts the oxygen hemoglobin curve up and to the left, which decreases oxygen exchange at the tissue level. Hyperventilation does not increase oxygen saturation. In aviation, the primary treatment for suspected hyperventilation is to administer oxygen, unlike the treatment of hyperventilation in terrestrial settings where you would reassure the patient and instruct them on how to monitor the rate and depth of breathing. That's about all the time we have for this session. Thank you for participating.